Good morning, everyone, and thank you for joining Diabetes and You, Controlling Blood Sugar One Day at a Time, a joint presentation from the Diabetes Foundation and Cooper University Healthcare. All attendees are in listen-only mode. If you have questions during the presentation, please use the Q&A feature in Zoom, and we will get to them at the end of the presentation. Now, it is my honor to introduce the Executive Director of the Diabetes Foundation, Janine Salente. Janine?
Thank you all so much for being with us today. It is my pleasure to welcome you to the Diabetes Foundation's workshop, Diabetes and You, Controlling Blood Sugar One Day at a Time. As Jim said, my name is Janine Salente, and I'm the Executive Director for the Diabetes Foundation, and I'm going to begin by briefly describing the work of the Foundation before I turn the presentation over to Michelle Laranko to present our workshop. Please know that today's workshop is approximately 1 hour, and Michelle will present for about 40 to 45 minutes, and then there'll be Q&A at the end of the presentation. Throughout the webinar, if you have a question, please write them in the Q&A icon at the bottom of your screen, and I'll present these questions at the end for Michelle to answer. For the past 30 years, the Diabetes Foundation has been helping people from Bergen County through Camp Nejeda to manage their diabetes, from offering free insulin, diabetes supplies, A1C testing, transportation assistance, and educational programming like our webinar today to support diabetes prevention and management. Our educational programming alone serves more than 1,000 people each month through webinars like this, Facebook Live yoga, and low-impact exercise programs, as well as diabetes care videos. Our free medication assistance, supplies, and other tangible services are well known throughout the healthcare industry as an efficient, available opportunity to help people stay compliant with their diabetes care. Our agency is the only one of its kind in the state of New Jersey, helping thousands of people and their families since our inception 30 years ago. COVID-19 has added additional concerns for those with diabetes, and finding the right healthcare to ensure you can manage your diabetes is of utmost importance. We are grateful to Michelle Laranko for being here today to provide her expertise to Diabetes Foundation participants to help us understand tools and techniques for managing blood sugar. Michelle Laranko has been a practicing nurse for 40 years. During this time, she was drawn to caring for children and adults living with diabetes. In 2001, she left her staff nurse job in pediatrics at Cooper Hospital to become a diabetes educator, and spent 10 years working with children diagnosed with diabetes and their families, school nurses, coaches, and anyone else who were involved in the care of these children. During that time, she became part of the Camp Nejeda staff, working as a cabin nurse, charge nurse, and pump nurse. And Michelle did some brief time with an insulin pump company before returning to Cooper University as a member of the Diabetes Wellness Center. She works with adults diagnosed with type 1 diabetes and type 2 diabetes. She does individual patient education appointments, teaches classes, and does insulin pump trainings and CGM trainings. Her fondness for people living with diabetes comes from her history of herself being diagnosed with type 1 diabetes at the age of 12. And she loves technology, as she can appreciate how far we've come in the care of diabetes since she was diagnosed. She's married with 3 adult children. Her oldest child was also diagnosed with type 1 diabetes at the age of 3. And we are all, she is waiting for a cure for type 1 diabetes and for COVID-19. And Michelle, I'd now like to turn the presentation over to you. Thank you so much and welcome.
Thank you for having me today. So I kind of wanted to put together just some basics, and I hope that you can find some of this interesting and learn something new, and if not, just reinforce what you already know. So I wanted to start with a description of what diabetes mellitus is. And it's really kind of interesting. The word diabetes comes from the Greek word for siphon. In the 1st century AD, it was noted that some people had a disease that resulted in the siphoning of structural components of the body into the urine. So in other words, they noticed that people were losing weight and they were urinating a lot. The word mellitus comes from the Latin, meaning sweetened with honey, and in 1674 it was noted the urine of certain patients was very sweet like honey. 1875, there were two additional descriptions given: diabetes maigre, which means diabetes of the thin, and diabetes grasse, which is diabetes of the fat. And then in December 1921, the first human treatment was with a substance extracted from the pancreas of a dog was created. So the present day definition of diabetes is a disease in which the body's ability to produce or respond to the hormone insulin is impaired, resulting in abnormal metabolism of carbohydrates and elevated levels of glucose in the blood and urine. So basically, diabetes is a disease of either inability to produce insulin or to produce insulin and have it not work the way it should. My definition of diabetes is a disease affecting the ability to regulate blood glucose. It's different in every person. It causes different needs for different medications and different ways to treat the disease. No two people are the same, and neither is their diabetes. What works for one person may not work for another. We're all different shapes and sizes. We have different sensitivities to things like food, activity, medication, and each of us can try the same thing and get different results. What works one day, many of you know, may not work the next day, and that can be due to environmental interference such as bodily functions. And we take our diabetes one day at a time and enlist a team to help us with a wonderful life living with diabetes. So who's on your diabetes care team? Hopefully your family and friends are available to support you and help you. And, you know, I think there's nothing more important than having family support and friend supports of your diabetes. You should have your health care. So that would be your primary care physician, a physician's assistant, nurse practitioner, advanced practice nurse, and endocrinologist. Hopefully you've got a certified diabetes care and education specialist. Now, that could be a nurse, a doctor, a dietitian, a pharmacist who's certified to provide diabetes education. A dietitian, it's always good to meet up with a dietitian once a year and just kind of go over how things are working. Ophthalmologist, an eye doctor's appointment necessarily every single year. A foot doctor or a podiatrist. Your pharmacist, a lot of our pharmacists can get very involved in your care. A dentist, you should always see the dentist at least once a year. And sometimes we need mental health and professional help. So anytime there's chronic illness, there can be an increased rate of depression. So having somebody that is, you know, helping you talk through things or work through things, or if medication is necessary. And then of course, an exercise physiologist or a trainer or a physical therapist. So let's talk a little bit about the types of diabetes. Type 1 diabetes, it's an autoimmune disease. The way I like to think about autoimmune diseases are, you know, antibodies are produced in the body to fight a disease or an infection. So you hear about antibodies all the time with COVID. We're talking about people that have COVID and get over it, then they have antibodies. But an autoimmune disease, the body produces antibodies that actually attack a part of the body. And in type 1 diabetes, it attacks only the part of the pancreas that makes the insulin. The rest of the pancreas is doing its job. It's just that part that's making the insulin. So originally, we called it juvenile diabetes, and we said people under 25 years of age had type 1, and people over 25 years of age had type 2. That we don't stand by that anymore. We found many different things, and I'm going to kind of go into that. So some of you may have heard of LADA, or you might hear of adult type 1 diabetes, or type 1 diabetes in adults. LADA stands for latent autoimmune diabetes in adults. And it is much like type 1, but it's diagnosed at an older age, obviously older than 25. I've had patients that are diagnosed in their 70s. And of course, the onset may be a little bit slower. If you know a child that was diagnosed with type 1, often they end up very, very sick and in the hospital very quickly. In LADA, it can be very prolonged. It could be a period of months or even a year before they're diagnosed. And they may initially be diagnosed with type 2 diabetes. It may be a couple years before they actually get the diagnosis of LADA. And sometimes there's some insulin resistance, which we don't often see in type 1. Type 2 is a disease of insulin resistance and multiple other metabolic abnormalities, which can result in insulin deficiency. So insulin resistance just means that the insulin is being produced, but the body can't use it the way it's supposed to use it. So initially it starts to make extra insulin. But of course, if we're always making extra insulin, the pancreas is always working harder and working harder, the ability of the pancreas to produce insulin over time may decrease, resulting in the need of insulin. Gestational diabetes is diabetes that is diagnosed during pregnancy. When a woman is pregnant, she has an increase in sex hormones like progesterone and estrogen. And those sex hormones make us very insulin resistant. So for most women, when they get pregnant, they just make extra insulin. But some women don't have that ability to make enough insulin, and then they get diagnosed with gestational diabetes. It often will go away once the baby's born. The hormones go back to normal, the resistance decreases, and life is good again. But we do see a high incidence of developing type 2 diabetes much later, or actually not much later, could be months or years after having gestational diabetes. There's a type of diabetes called MODY, mature onset diabetes of youth. This is an inherited collection of different types of diabetes. There's many different kinds of MODY, and it results in a combination of insulin resistance and insulin deficiency, and it's usually diagnosed in the youth, but it can also be misdiagnosed as type 1. And then later picked up as MODY. Diabetes can also be caused by some other diseases like pancreatitis or cystic fibrosis or pancreatic cancer. It can also be caused by drug or chemical-induced diabetes. A lot of our HIV and AIDS medications can cause diabetes. Agent Orange, we know, can cause diabetes. High-dose steroids can cause diabetes. So there's a lot of drug or chemical-induced diabetes. We have prediabetes, also known as glucose intolerance or impaired fasting glucose. And this is a condition when the blood glucose is higher than normal, but not high enough to be diagnosed with diabetes. So usually the A1C is somewhere between 5.7 and 6.4. I'm going to talk a little more about A1C in a minute. And then there's something called diabetes insipidus. Diabetes insipidus has nothing to do with the diabetes we're talking about. We are talking about diabetes mellitus. Diabetes insipidus is a completely different, unrelated disease, and it has nothing to do with insulin or blood glucose. So what is insulin? And well, insulin's a hormone produced in the tail of the pancreas. It's released into the bloodstream, and it regulates the glucose in the blood, and it helps to move the glucose into the cells, providing energy for the cells. We produce it in two different ways. There's background insulin or basal insulin, and that's just a small amount of insulin that the pancreas is releasing into the bloodstream constantly 24 hours a day, and it maintains the blood glucose at a steady level throughout the day and night. We also have mealtime insulin or bolus insulin, and this is when somebody eats, the pancreas gives a huge burst of insulin, and that insulin allows them to use sugar for energy, move the sugar into the cells. It helps with the breakdown of the carbohydrates. So just remember, diabetes is like a car. Think about your car. You've got a great engine in the car. You got a full tank of gas in the car. But what happens if there's a clog in the fuel line? The engine's not going to run. So the body's cells are our engine. The gas is our glucose or the carbohydrates that we eat. But if you don't have the insulin, which is like the fuel line, you can't transport the glucose into the cells, and the body doesn't run. So because of that, we often feel very tired, very lethargic, and basically the feeling is caused by the cells not being able to get the glucose or the energy they need. So one of the first symptoms we hear people complain about when they're being diagnosed with diabetes is they may say that they've been feeling very tired lately. Another symptom would be excessive urination. So your kidneys their job is to clean the blood. And sugar, it's a good thing. It should be in the blood because our cells need it for energy. But when the sugar gets to be too much, the body sees it as a poison, and it starts to excrete the glucose into the urine. The kidneys pull it out and get rid of it. And obviously, if there's a lot of sugar, you're going to make a lot of urine. So you'll be getting up 2 and 3 times a night to go to the bathroom. Since urine is made up with water and waste products, we can develop excessive thirst, as the more urine you put out, the more dehydrated you get it. The more dehydrated you get it, the more you want to drink. So you wake up in the middle of the night and go to the bathroom and then have a glass of water. Weight loss can be seen. Again, if the body is not getting energy, the body's going to die. So the body doesn't want to die, and it will do things to keep things right. And one of the things it'll do, it'll start to break down body stores, it'll break down fats, it'll break down muscle, and it'll convert that sugar, those body stores to energy, to sugar, which makes the sugar go higher. Unfortunately, without the insulin, we can't use that extra sugar. So what we see is, you know, all of our symptoms plus weight loss and a high blood sugar. Some people complain of excessive hunger. Again, if the cells are not getting what they need, if the brain is not getting what it needs, it's going to send out a message saying to eat more food. We may have some blurred vision when there's prolonged high blood sugars. The lens gets a coating over it, the lens of the eye, and that coating causes blurring of the vision. When the glucose is in better control, in a matter of days or months, the glucose control, it allows that lens coating to break down and the vision goes back to normal again. We could have some slow healing cuts and wounds, again, and that's due to damage to the blood vessels, not being able to transport oxygen and nutrients. It's not uncommon to see vaginal yeast infections or yeasty skin infections in the folds of the skin, jock itch in males. And again, the overabundance of sugar causes yeast to multiply. And then some numbness and tingling in the extremities, and this is damage to the blood vessels, which prevent the nerves from getting getting the nutrients they need, and then the nerves become damaged, causing the numbness and tingling. Here we use the ADA, the American Diabetes Association targets. Now remember, these targets are for somebody that has diabetes, okay? If you don't have diabetes, then the targets are completely different. But if you do have diabetes, the pre-meal target is 80 to 130. 2 hours after the first bite of the meal, not 2 hours after you finish your meal, the glucose should be less than 180. And before bed, if you're taking a blood glucose lowering medication like a sulfonylurea or insulin, then a blood sugar of 100 to 140 before bed. For pregnancy, we have very strict targets because we know that high blood glucose during pregnancy can affect the baby, it can affect the size of the baby, and late in the pregnancy, it can affect both the baby and the mother. So the pre-meal sugars should be 60 to 90. 1 hour after the first bite of the meal, less than 140, and 2 hours after the first bite of the meal, less than 120. So I talked a little bit about an A1C. An A1C is a blood test that we do, and we consider it to be a 3-month average. Our red blood cells live for 3 months in the body, then die off. So we look to see how much sugar has attached to those red blood cells. And a normal A1C would be less than 5.7, pre-diabetes 5.7 to 6.4, and diabetes with decreased risk of complications less than 7. But so this is a little picture in the upper left. You can see that's a healthy red blood cell with a little bit of glucose attached, and on the right in that picture is the red blood cell with a lot of glucose attached. But I want you to be aware that that 7%, that is a generalized A1C. So when we're looking at A1C targets, you really want to talk to your healthcare professional and find out what your target is. When we look at A1Cs, there's a lot of things that need to be taken into account. If you have somebody who's young and healthy and has no other complications and no other diseases and nothing else going on, then definitely an A1C 7 or less. But as we age, we have less symptoms of low blood sugar, so we may not want to keep that blood sugar so low, so the A1C target may be 7.5. If we have heart disease, we may have a A1C target of 7.5 or 8. So again, please talk to your healthcare professional and find out what your target is. Why does blood glucose rise and fall? Well, 3 things. Food, medication, and activity. These are the controllable factors. You eat more food, you go high, not enough, you go low. Medication, are you taking your medication correctly? Are you taking it at the time you're supposed to be taking? Are you taking the right amount of medication? Are you prescribed the right amount of medication? Does the dose need to change, or does the medication need to change? Activity, When we're active, we're burning energy. Energy comes from glucose. So the more active I am, the more glucose I burn, and the lower the blood sugar goes. The less active I am, the higher the blood glucose, because I'm not burning it. And then the one factor that is completely uncontrollable is stress. Stress also affects our blood glucose, but we have no control of that. It would be wonderful if we could say, I'm going to have a stressless day today, but that doesn't happen. So the uncontrollable factor is the stress. Typically, we'll see a rise in blood glucose when somebody's stressed. Stress can be mental stress, like worrying about the taxes or the bills. Stress can be physical stress, like being sick or having COVID. It could be having a broken bone, being in pain. But stress can elevate the blood sugar in most cases, and in some cases it will lower it, because again, we're all different. And having a way to deal with your stress is extremely helpful. So whether you do meditation or you listen to music or yoga, martial arts are a great way of dealing with stress, talking to someone, and if needed, medication to help deal with stress. So what are the treatments for diabetes? Well, lots of treatments. Type 1 is always going to be insulin. If you can't make insulin, you have to replace insulin with insulin. And there is no insulin other than injectable insulin at this time. There are no pills. You need to inject insulin in one way or another, whether it be from a pen, a syringe, or whether it be from an insulin pump. But type 1, the treatment's always going to be insulin. LADA may initially be controlled with diet and meds. Could be some pills. Eventually, they're going to need insulin, because in LADA, the autoimmune response will continue to the pancreas is no longer able to make insulin. Type 2, when you're first diagnosed, diet and exercise can work. If I diet, I'm eating less food. If I exercise, I'm burning sugar with my energy. But sometimes over time that stops working. Then we can start to add medications. There are multiple different kinds of medications, and there are multiple different problems that develop during type 2 diabetes. In some cases, it could be that the liver, which stores sugar, is putting out too much insulin. In some cases, it could be related to diet. So again, many different treatments for type 2 diabetes. I'm sure you see all the advertisements on TV. MODY can be controlled with pills or insulin. In gestational diabetes, it may initially be controlled by lifestyle changes, but if the glucoses are high, they may add insulin. And again, the insulin is usually only during the pregnancy. Once the pregnancy is over and the baby's delivered, things go back to normal, the insulin stopped. So, in general, for everyone, treatment will also include diet and exercise. So we teach now a healthy diet, a balanced diet, by eating foods from all of the food groups. We're going to get better control of our blood glucose. We're going to prevent the blood sugar from spiking, and we're going to maintain the glucose so it doesn't drop. Okay, so your carbohydrates are going to be your starches, your milk, and your fruit, and all of those foods are going to raise the blood glucose. But the protein, like your meat, fish, seafood, poultry, eggs, cheese, your fats, like your butter, your oils, your nuts and seeds, and your non-starchy vegetables are going to help prevent the glucose from rising, and it's going to help to maintain the blood sugar where it is. Exercise improves the body's resistance to the insulin. So if you have type 2 diabetes, the insulin is going to work much better if you're being active. But one of the things we know is that if you stop being active for more than 2 days in a row, it can revert back to the same resistance you had. So here's a question for you. Is sex exercise? There's nothing like getting a low blood sugar alert in the middle of a romantic moment. Yes, sex is exercise. So how about blood glucose testing? It's one of the most important things you can do. Knowing where your glucose is can help you plan where you're going and what you need to do. A blood glucose gives you the information you need now, and it helps your healthcare provider decide what treatment is working and what treatment is not working. It allows you to see what happens with your meals, what's working and what's not working. Is it a good meal or not so good? It also allows you to see how the activity affects your glucose. Testing can be by a finger stick, or it can also be by a continuous glucose monitor. I just want to remind you, if you're using finger sticks, please warm soapy water when you're home, dry the hands well, use the sides of the fingers. The pads of the fingers have many, many nerve endings. We don't want to be sticking the nerves because you'll be sending nasty messages to your brain. Sides of the fingers have very few nerves, so by using the sides of your fingers, you'll have less pain. And some people will use alternate site testing. I will tell you it's not as accurate as finger sticks, but definitely better than no testing at all. A continuous glucose monitor is a system, a sensor that's stuck into the body by the person who's wearing it. It is not measuring blood. It is measuring the glucose and the fluid around the cells. That means it's about 10 minutes behind what's happening in your blood. The blood is always most accurate, but there are two systems on the market right now that are FDA approved for therapeutic use. In other words, that means that you can use the readings from the systems in place of finger sticks. But please always remember, finger sticks should be done if you're feeling low, so you know exactly where you are. It should also be done as a follow-up to a low, because the CGM is going to be about 10 minutes behind. So the rule for lows is rule 15 grams, wait 15 minutes. And of course, in 15 minutes, the CGM is not going to be reading that your blood glucose has come up, but the blood glucose hopefully has come up. Some systems will need calibrating, which means you do a finger stick. Some systems have alarms that alarm for high and low glucoses. Some are integrated with pumps, and many of our insurances cover them. This is just some pictures of some CGMs that are on the market now. So earlier I said there's something better than an A1C, and that thing that's better is called time and target, or time and range. When you have a continuous glucose monitor, it does have some reporting software. So you can pull reports from the system. You can look back at a week, 2 weeks, 30 days. Some of them go back 90 days. And the systems will actually give you reports and tell you what's been going on. I see a pattern of highs in the morning. I see a pattern of lows overnight. But it'll also give you the time and target, the time and range. So an A1C is an average. And for those of you that are math people, you know that an average is all of your numbers added up and divided by the number of numbers you have. So you could have a lot of highs and a lot of lows and still have a good number. The time and target is actually telling you what percentage of the day is within the target range. And we are shooting for 70% or better. So easy to remember, the A1C target we're shooting for is 7 or less. Time and target is 70% or better. And then it's important to look at our lows. I like to say that a high can kill me in 10 years. If my blood sugar is always high, I could have a stroke or a heart attack. But a low could kill me today. If I have a low blood sugar, I get behind the wheel of my car and I drive. I could crash my car, it could take me out, and I could take 10 other people with me. So our lows should definitely be less than 4% or less, 4% or less. So we definitely want to look at the amount of lows somebody's having. And this is what a time and range or time and target scale can look like, okay? So healthy eating, I already talked a little bit about this. We teach the healthy plate. And again, the healthy plate is looking at a plate. I'm going to show you a picture here. So the plate should be half non-starchy vegetables, half a quarter starch, a quarter protein, and then throw in a milk and a fruit now and then. So there is no real diabetic diet anymore. We don't give people diets and say, eat this, eat this. We try to get everybody, whether they have type 1 or type 2 or gestational, we try to get them to eat from the healthy plate. Get all of your food groups every day. So our food groups, we don't have a dairy group anymore. There's a milk and yogurt group. The fruit and fruit juice and our starches, they are all carbohydrates. They are very important to the body. They're going to break down in your body and turn to sugar, and that sugar is what's going to give your body energy, provided there's enough insulin to use that sugar. If there's not enough insulin to use that sugar, the glucose is going to go high. Free foods are foods that digest slowly. and they help to slow down the conversion of the carbohydrates to sugar, are your proteins, your non-starchy vegetables, and your fats. So what's the whole grain buzz? We talk a lot about whole grain anymore. Well, a grain of wheat consists of the bran, the endosperm, and the germ. And when we have whole wheat, we take all of that and we do a little bit of processing and end up with whole wheat flour. When we have white flour, we strip away the bran, we get rid of the germ, whatever's left, we process and process and process. Think about it. One is barely processed and all of the parts are there. The other is stripped down and very processed. When you eat those foods, which one do you think will turn to sugar quickly? Obviously, it's the one that's stripped down and the one that's very processed. So the white flour, when you eat it, will break down and turn to sugar very, very quickly. That quick rise in the sugar will cause the blood glucose to spike, which causes more damage to our body. So whole grains are definitely more beneficial to us when we have diabetes. It helps us control our blood glucose. Some other whole grains besides wheat are barley, brown rice, buckwheat, bulgur, corn, millet, oats, obviously wheat. When you're looking at a label and you look at the ingredients, the first ingredient should say whole wheat flour or whole barley or brown rice. If you're seeing the word enriched wheat flour, it has been altered and it has been processed. It is not a whole grain. So all of you that have your wheat bread at home, please go in the drawer and look at it and see if it's enriched wheat flour or whole wheat flour. This is just a little picture of some simple carbs and some more complex carbs. So obviously a simple carb is going to turn to sugar very quickly, like the Coke and the donut and the M&Ms. And then the more complex carbs are going to break down slower, giving a slower rise to the glucose and preventing that damage to our small vessels like our eyes and our kidneys and our feet. All right, so when you have a low, I already mentioned the rule of 15. I can't stress enough how important this is. And I can't tell you how many years I lived without understanding this rule and doing the wrong thing, okay? So the rule of 15 is 15 grams of a fast-acting carb, wait 15 minutes, and recheck the blood glucose. A fast-acting carb is a food that is going to turn very, very quickly to glucose in your stomach and be very quickly absorbed to the blood and moved out to the cells to raise the glucose. Fast-acting carbs would be glucose tabs. You do have to eat 4 of them. It could be 4 ounces of juice or regular soda. It doesn't have to be orange juice. It can be apple juice or fruit punch. It could be fruit snacks, a tablespoon of honey, 4 packets of sugar. Just remember, you want something that is going to turn very quickly to sugar. Back in the day, it was not uncommon for me to grab a bowl of ice cream or a piece of cake. Bad choice. Things that have fat in them, things that have protein in them will turn to sugar, but they're not going to turn to sugar quickly. So that chocolate bar, chocolate is a fat. That chocolate bar is going to wait and sit and break down slowly. So what happens is your blood glucose is low, you grab that delicious chocolate bar, you eat it, you check your blood sugar in 15 minutes, you're still low, so you eat some more of the chocolate bar, you wait 15 minutes, you check your blood sugar again, it's a little better, but you're thinking, gee, I must have been really low, and you have a little more chocolate bar, and then 2 hours later, your blood sugar is 300. So please, when your blood glucose is low, stick to the fast-acting sugars. Always, always carry something with you. Remember, your brain runs on sugar. If the glucose is low in the blood, the brain is not getting what it needs, which means you could pass out, have a seizure. We don't want that to happen. So please, always, always carry something with you and make sure it is a fast-acting sugar. How about some label reading? You may have noticed the labels are a little bit different now. They've changed over time. Unfortunately, I don't have two new labels here, but what I wanted to show you was the difference between the 2 labels. The label on the left, I'm always looking at my total carbohydrate because carbohydrate is what turns to sugar. The label on the left has 37 grams of carbohydrate and the label on the right has 37 grams of carbohydrate. The difference is the label on the left only has 1 gram of sugar, where the label on the right has 12 grams of sugar, okay? So what I'm seeing here is how fast it's gonna raise my blood sugar. They're both 37 grams, so the amount of rise is gonna be pretty much the same. The difference is the one that has 12 grams is gonna raise my blood sugar faster than the one that has 1 gram. So people come in all the time to see us and they'll say, I never eat anything that has more than 5 grams of sugar. Well, let me tell you, if they're eating the product on the left that has 37 grams of carbohydrate, they're not doing themselves a favor. It has less than 5 grams of sugar, but it's still gonna raise the blood glucose considerably. So when you're looking at labels, please look at the total carbohydrate. If you're comparing 2 things, so let's say we had 2 cereals, and both of the serving sizes are 2/3 of a cup, and both of the cereals have 28 grams of carbohydrate, but the one cereal has 18 grams of sugar, and the other cereal has 10 grams of sugar. That's when you can use the sugar to make a decision about which is the better choice. Obviously, the lower the sugar, the slower the rise in your blood sugar, and the better off you're gonna be. So the one with the 10 grams would be a better choice than the 18 grams of sugar, but know that they're both gonna raise your blood sugar about the same. So, often we don't look at our after meal blood glucoses. We're always told to check before we eat our meal. If you're using a continuous glucose monitor, you are looking at your after meal blood glucoses. But we do have diabetes, and that blood glucose is gonna rise. The insulin that we're taking, or if you're making your own insulin, it's not releasing the way it's supposed to be. Or if you're taking medications to help you make more insulin, it's not working as fast as it should. So when you have diabetes, the glucose is gonna rise after the meal. But again, we wanna keep that rise to about 40 to 60 milligrams per deciliter above where you started. So if you started at 100, hopefully you're hitting maybe 140, 160, life is good. If you're hitting 200, 250 after the meal, we need to look at either your medication or how you're putting your meal together. If you're eating just carbohydrates, it's gonna rise pretty quickly. So again, our blood glucose should rise after the meal. This is giving you a little idea of what happens here. So on the left is the healthy response, and you can see they started out a little bit before 90, and they came up to about 120 and then came back down again. Now on the right, it's giving you a little bit idea of how our nutrients break down. So you can see that orange, how quickly our carbohydrates rise. So you can see how quick that blood sugar goes up with the carbohydrates. You can see the fat, which is the green, and the protein, which is the yellow. It does rise a little bit, but out 3 hours later. So again, it helps to slow down those carbs. How often should you eat? Well, years ago, we taught people on insulin to eat 3 meals and 3 snacks, and that's because the insulins we used had peaks and valleys, and we always wanted to have insulin on board when there was a peak in the insulin. So we would eat and then we'd have a snack, and then we'd eat and then we'd have a snack, and we'd eat and then have a snack. We hardly ever use those insulins anymore. So again, most people don't need to have those 3 meals and 3 snacks. If you're making your own insulin, if you're not taking insulin, you actually may be better off eating more frequent, smaller meals, because if you're making your own insulin, you may not be putting it out in big spurts. And eating little bits now and then might allow your insulin to work better and allow you to produce and put out the insulin the way you're eating. But if you are taking insulin, then you really should be sticking to 3 meals a day and not snacking between the meals, okay? So if you're taking insulin, and you're snacking, then what's happening is that blood sugar is rising during the snack. Just remember, if you put food in your mouth, you need to have insulin in your body. And if you're taking insulin, if you put food in your mouth, you need to take insulin. All righty, so is sugar-free really sugar-free? That's a great question. If you look at a label and it says there's 0 carbs and there's 0 calories, it is really sugar-free and you can have all you want. But if you look at the label and there's calories and there's carbs and it says that there's sugar alcohols, it is not sugar-free. The sugar alcohol is just an altered sugar. It's been changed. And when they alter the sugar, it breaks down slower than sugar. So you may not get that quick rise that you would get with sugar, but it is going to raise the blood glucose. And also, our sugar alcohols tend to have a laxative effect, which can cause bloating, gas, and diarrhea. When you look at these labels, on the left, you can see the Hershey's sugar-free. On the right, it's the regular Hershey miniatures. And if you look, the serving size is 5 pieces. And the sugar-free has a total carb of 24 grams, and it has 17 grams of sugar alcohol. The real Hershey's on the right, the total carbs are 25 grams, so they're almost identical, and the sugars are 22 grams. So the difference is the ones on the left, the sugar is going to break down slower. For some people, that may be a benefit. The sugar on the right, or the Hershey's on the right, are going to turn to sugar a little bit quicker, not the way we want our blood sugar to rise when we have diabetes. So let's move on and let's move. So why do we talk about exercise? Well, it improves the quality of life, builds strength, endurance. It preserves our balance and flexibility as we get older. It lowers our blood glucose. When we have insulin resistance, it helps to decrease the insulin resistance and help your own insulin work better. Or if you're taking insulin, it helps the insulin you're taking work better. It improves our mental health and it decreases stress. It improves motivation, circulation, heart health, and it lowers our blood pressure and cholesterol. So there's some studies that were done. I love studies. I love when people prove things to me. You may have heard of the 10,000 step study. It was done in the 90s. And what they did was they had a group of people walk 10,000 steps a day. They didn't start out walking 10,000 steps. They had them use a pedometer, and over time, they increased their steps till they got to 10,000 steps a day, and then they stayed there. And what they saw in the first 4 weeks, there was an improvement in the glucose, the cholesterol, the weight, and the fitness. And that was just in 4 weeks. At the end of the study, 58% of the people in the study who had pre-diabetes did not develop diabetes, and they lost 5 to 7% of their body weight. So please get up, get moving, and start walking. Walking is an excellent, excellent exercise. Very popular now is interval training, and basically all that is alternating periods of intense exercise with rest. An easy way of doing it is going out and going for a walk and look at the street lights on your block. So you walk very fast to one street light, and then you slow down to the next street light, and then you pick it up and walk fast again. And what we found is that it burns more calories than a regular workout. And it also helps burn calories for the next 24 hours. But again, the sessions should not be more than 20 minutes at a time, and we should not be doing it for more than 3 times a week. I mentioned earlier that if you're exercising regularly, it helps decrease your insulin resistance. But if you skip more than 2 days in a row, it takes you back to where you started again. If you want good health, you should be exercising 5 times a week for 30 minutes. If you want to lose weight, 5 times a week for 60 minutes. And again, combining different types of exercise can be very beneficial rather than doing the same thing over and over. Exercise can be chair exercises, it can be aerobic exercises, it can be anaerobic exercises, but they don't all work the same way. So some exercise lowers the blood glucose, but some exercises actually raise the blood glucose. So when we do some anaerobic exercise like weights and strengthening, it tends to increase the blood glucose. But over time, it improves the body's health. And usually that blood glucose will come back to normal again later. So it's very important, back to testing again, to test your glucose before you exercise and after you exercise so you can see how that exercise affects you. Obviously, if you're doing an exercise that lowers the blood glucose, you want to be prepared for that. When we're taking medications like insulin or medications that help produce more insulin, like sulfonylureas. The best time to exercise is after a meal, and that way we can prevent the low blood sugars. And always be aware that we could have delayed hypoglycemia, which just means that during the exercise, you borrow a little bit of the stores of liver glucose that we have, and then hours later, 6 to 12 hours later, sometimes 24 hours later, the liver says, hey, remember that sugar I gave you when you were exercising? Well, now I want it back. And the liver starts pulling the glucose out of the blood and stirring it up, and the blood sugar drops low. So delayed hypoglycemia is dropping low later. So what's next? We've got lots of technology. It's been tremendous in the last 10 years. We have new pumps and CGMs. We have lots of phone apps. As your knowledge continues to grow, your ability to think through what is happening and what your next step should be improves. And a yearly visit to a diabetes educator is an excellent way of keeping on top of your game. So I recently did a talk to Camp Nejeda's adult boot camp. It was called Survive and Thrive. And I just wanted to throw this in there. This is me, that picture right in the middle, the Girl Scout. That was taken about a week before I was diagnosed with type 1 diabetes. And then the rest of the pictures are me. And on the bottom to the left of that Girl Scout is me and my husband and my youngest, my daughter. We had a little COVID wedding in July with a couple people back to the house for dinner. It wasn't a big deal. Next year we intend to have the big deal, but the wedding got moved 3 times. I think I've survived and I've thrived. Last week was my 48th anniversary of living with diabetes. And, you know, I just want to make it perfectly clear that with good knowledge, good education, and a lot of hard work, we can definitely live long, happy, healthy lives with diabetes. Thank you.
Thank you so much, Michelle. That was terrific. And thank you all for joining us for the Diabetes Foundation's webinar, Diabetes and You, Controlling Blood Sugar One Day at a Time. We have 12 minutes for questions. And we have a couple of questions that came up on the chat box. So the first one is, snacking between meals, do veggies count? And how do you control hunger between meals if you can't eat?
Okay, good question. So yeah, there's not a lot of good snacks when we have diabetes. Absolutely. The non-starchy vegetables are a great snack. So, you know, carrots and dip, you know, usually our dips have a very small amount of glucose, of sugar in them, and carrots have a very small amount of sugar in it, so we don't really worry about that. You know, celery and cream cheese, celery and peanut butter, all good. Nuts, seeds. Now, a handful of nuts is considered a serving, but if you eat the whole can of nuts, that is going to raise your blood glucose, okay? If you eat anything in large amounts, even if it's protein or non-starchy vegetables, in a large amount, it's going to raise the glucose. It's not going to raise it immediately. It'll raise it over time. So again, we've always got to be careful. So what are good snacks? Veggies, dip, peanut butter, nuts, seeds. You could take, you know, some lunch meat and roll it up and make a little lunch meat roll, or a piece of cheese, a couple pieces of cheese. So things like that can be helpful. And, you know, and again, protein helps to fill us up. Fiber, which are in your non-starchy vegetables, helps to fill us up. Fats helps to fill us up. So those kind of foods, you know, sometimes are boring, but they're things that we can eat that are going to give us, you know, a fuller feeling and hopefully keep that blood glucose from rising too much.
Michelle, so the same participant just asked, with that snack, do you take insulin with that?
So none of those foods you would want to take insulin with, okay? They're all, you know, they're all in like the free food category. So I would not take insulin with it. If I was going to have cheese and crackers, I use an insulin pump. So if I was going to have cheese and crackers, I would definitely give insulin for my crackers, okay? If I was having a snack that was either a starch or a fruit or milk or yogurt, yes, I would absolutely give it. And let me back up a little bit. Fruit is really important. You know, we need lots of minerals and vitamins from the fruit, but we should never be eating fruit alone because fruit has a very fast sugar in it. We tell you to drink juice when the glucose is low. The juice is even faster because we've removed the fiber from it. But fruit itself has a very fast sugar in it. So if we're eating fruit for a snack, it's really going to give us a big spike on it. So if you're having a snack and you're having some fruit, please add some protein or some fat to it. So some peanut butter or some cheese, you know, have something else with the fruit. Don't eat it alone.
Okay, terrific. Thank you so much. The next question is, the participants interested in knowing which, if any, do you use as a continuous monitor solution? This person is type 2 and wondering, would it be better to change to one of them?
So I love continuous glucose monitoring, not because I don't not because I don't stick my fingers. I do love not sticking my fingers, but the beauty of the glucose monitor is you learn so much about yourself, about your food, and about your activity. If you're really using your monitor, it is a beautiful thing and it can be a life-changing event. Okay, many people get a continuous glucose monitor because they don't want to stick their fingers anymore, and that's awesome. But the thing is, now you're seeing exactly what's happening. When I have that plate of spaghetti and meatballs, I know exactly what happens after I eat. Now I can change that, okay? So maybe I eat my spaghetti and meatballs and my blood glucose goes very high afterwards. What can I do differently? Well, I'm not going to give up my spaghetti and meatballs, but maybe next time I'll have a little less pasta and my tomato sauce will have a little more peppers and onions. Maybe I'll throw some broccoli in there. So I'm going to get a little more veggie in that meal. I'm going to have my meatballs, which are my protein, and then I'm going to watch and see what happens with my blood glucose. And hopefully I'm going to get a better result this time. So a continuous glucose monitor is giving you information 24 hours a day. What happens when I go to bed at night? When I get on the treadmill, what happens to my blood glucose? When I lift weights, what happens to my blood glucose? I love continuous glucose monitors. I think they're fabulous. I think that if they're affordable, we should have them. Sometimes they're not affordable. They're all good. Libre, Libre 2, Dexcom, they all do not require finger sticks, but it doesn't mean you're going to throw your meter away because they have warm-up periods where you might need to check. And again, remember I said it's a little bit behind your blood. So if you're feeling low, you should be doing a finger stick and seeing exactly where you are. I don't have a preference. I do use a continuous glucose monitor. You know, I think that the big difference is whether you have alarms or not. If you're somebody who's hardly ever having low blood glucoses, then a continuous glucose monitor that does not have an alarm is perfectly fine for you because you don't need to get those alarms. If you're somebody who does have low blood glucoses, you absolutely should have a continuous glucose monitor that alarms. So to back up, the Libre doesn't have alarms. The Libre 2 and the Dexcom do have alarms. So it really depends on you and what's going on with your diabetes. But if you get one, please see a diabetes educator and let them help you learn how to use the information. I do this all the time. People come in, we download their meters. They record their food for a week or two, and then we sit and we look at the meals and what happened with those meals and how we can alter those meals. I never say don't eat something. I always say learn how to eat it to help you rather than hurt you.
That's terrific. Thank you. And for everyone listening, if you need food logs, if you need information on potentially how to get that device, please contact the Diabetes Foundation. We can help. The next question is, are there any truly healthy desserts for a person with diabetes?
Truly healthy desserts. Okay, so let me put it this way. You know, I mean, it depends on what you like for dessert. I mean, angel food cake, I was diagnosed in 1972. Angel food cake was on my menu back then as a starch. So if you had a piece of plain angel food cake, they considered it to be okay. But let me just put it this way. If I was going to have a treat, okay, it's my birthday and I want to have a little piece of cake, not a Cheesecake Factory piece of cake, but a little piece of cake. what I would have is, first of all, it's going to be with my meal. I'm not going to eat it 2 hours later, because 2 hours later is going to make my blood sugar spike. And my meal is going to be a Caesar salad, because I love Caesar salad. I'm going to have a steak because I'm a steak kind of person. My vegetables are going to be mushrooms and spinach because I love mushrooms and spinach. I'm going to forgo my baked potato. I'm going to forgo my rice, my pasta, whatever. My dessert's going to be my little piece of cake. Now, where are my carbohydrates? There were no carbohydrates in my meal. I had salad, salad dressing, maybe a little bit of carbohydrate in my salad dressing. Salad, salad dressing, steak. I had 2 non-starchy vegetables. And my dessert will be my carbohydrate, and my carbohydrate will be my little piece of cake. So hopefully all of that protein, all of that fat, all of that non-starchy vegetables will help slow that cake down and give me a better result. I won't spike from the cake. The cake will work with my insulin, and hopefully I'll have a good result. And how will I know that? Well, if I don't have a CGM, I'll check my blood sugar 2 hours after I eat. If I have a CGM, I'll watch my CGM and see what happens.
Okay. The next question is about the food label. I thought the sugar amount on a label was included in the carb. Is that not true?
Yes, that is true. So on those 2 labels, they both had 37 grams of carbohydrate. The label on the left, it said 1 gram of sugar. What that meant was, of those 37 grams, 1 was sugar. Okay, on the label on the right, it was 12 grams of sugar, and 10 of them were added sugar. So by saying 10 added sugar, it means like 10 grams would be like 2 tablespoons of sugar. So they had 2 tablespoons of sugar in it. So it's like something that's added. You know, fruit has carbohydrates and fruit has sugar in it, but we don't add it. It comes from the tree or the vine. So yes, the sugar listed and the added sugar listed is part of the total carbohydrates.
Okay, I have 2 more questions about food. Do you have a preferred brand of yogurt to eat? And how much cheese and crackers can we consume in one meal, one time?
So yogurt, I like Greek yogurt. And the reason I like Greek yogurt is, if you think about the food groups, yogurt is actually in the milk group. Remember, I said there's no dairy. We have a milk group, and in the milk group is milk and yogurt. So it is a carbohydrate. So milk is, yogurt is going to raise my blood glucose. And I said that, you want to make sure you're having proteins or fats or non-starchy vegetables. So Greek yogurt typically has about 10 grams of protein per serving. So I always stick with Greek yogurt because it's going to give me a better after meal response or after yogurt response. And I'm a little bit on the chunky side right now. I caught that quarantine 19, not the disease, but the 19 pounds from being quarantined. And I'm trying to lose them now. So I stick to the light yogurts. And usually they have somewhere between 8 and 12 grams of total carbohydrate when I'm eating them. So definitely, if you're a yogurt eater and you don't mind Greek yogurt, definitely a much better choice. Cheese and crackers. Again, it really depends on the person and what's happening. If I ate 3 crackers, it would raise my blood sugar because I don't make any insulin at all, okay? But a lot of you make your own insulin, and you may be controlling with diet and exercise, or you may be using pills, or you may be using different kinds of medication. You may be able to eat 3 crackers and be fine because you're making your own insulin. So my answer to you is experiment. Luckily, I always liked science in school. And I always ask people, if you like science, you'll do good with diabetes. If you don't like science, it could be a problem. But whoever asked the question, do some experimenting. Do a blood sugar, eat a couple crackers, check your blood sugar an hour later or 2 hours later, see where it is.
Thank you so much. We do not have any more time for questions, but I just want to thank you again. Thank you everyone for coming on to this webinar. The Diabetes Foundation is truly dedicated to helping you get the education and the information you need to be healthy and living with diabetes. We have a lot of upcoming events every Monday on our Facebook page, Diabetes Foundation, Inc. At 10:30, we have chair yoga sessions for an hour. Every Tuesday and Thursday on the same Facebook page at 8:30 a.m., we have 20-minute low impact workouts with a certified trainer. Wednesday, November 18th at 4 p.m., we have a very special offering. It's called Journey Through Rhythm, and it's an interactive webinar series for kids of all ages to learn percussion, have the chance to express themselves. You can sign up on our website at dfiinc.org/events. On Monday, November 16th at 4 p.m., we'll be hosting a Facebook Live event titled Celebrating Life with Diabetes, and it's an interview with Marlene Korgold, who is one of the Diabetes Foundation's resource specialists, and she's had diabetes T1D for 30 years. And lastly, on Wednesday, November 25th, we're offering Voices of Diabetes. It's with Camp Nejeda, and you'll hear from 3 young adults living with T1D to share their experiences live. So please, if you need insulin, if you have any further questions, please contact us by going to our website, www.dfiinc.org, or calling us at 201-444-0337. Lastly, everything we do is free, with great thanks to individuals, corporations, and foundations, and wonderful healthcare professionals like Michelle. Thank you so much, Michelle, for doing this for us. We truly appreciate it. And all of the information you gave us was so valuable. So thank you all again for coming. Have a very nice day and stay safe.